I'm delighted to introduce our speaker this morning. Dr. Ankitha Madde was born and raised in Rochester, Minnesota. She attended undergraduate and for medical education at the University of Pittsburgh, and now is in her 4th year of obstetrics and gynecology residency here at the University of Wisconsin. Upon graduation, she plans to join a private practice in Connecticut. And today she'll be speaking to us about the Obstetrician and the Intensivist, a system-based framework for maternal critical care. Please join me in welcoming Dr. Ankitha Madde.
Hello, good morning, everyone. My name is Ankitha. Thank you so much, Dr. Panika, for the introduction. Today I'm going to be talking about the intersection between two pretty high-stakes worlds, obstetrics and critical care. My talk is titled The Obstetrician and the Intensivist, a systems-based framework for maternal critical care. Oh, here. So why is learning about critical care important? Well, despite advances in medicine, the global burden of maternal critical illness remains really high. Each year, over 800 people in the world die every single day from pregnancy, childbirth, or soon after. That's nearly 1 person every 2 minutes, which is a pretty jarring statistic. Worldwide, the maternal mortality ratio has improved by about 263 deaths per 100,000 live births, from 460 in 1985 to 197 in 2023, but this number is still very high. The figure here represents the global distribution of the cause of maternal death. The most common cause of maternal death between 2009 and 2020 was hemorrhage, followed by indirect obstetric deaths and hypertensive disorders. Indirect obstetric deaths include those that are related to underlying embolic or cardiac disease or other chronic conditions, associated conditions like multiple gestation, assisted reproductive technologies, and obesity. Abortion represented 8% of maternal deaths, pregnancy-related infection made up 7%, embolism made up another 7%, and other direct causes made up 10%. In low to middle income countries, the maternal mortality ratio is 14 times higher than in many high-income countries, and a majority of these deaths are deemed preventable. Critical care admissions in high-income countries is currently below 1%, and most of these end up being postpartum patients, whereas in low to middle-income countries, critical care admission rates range anywhere from 0.13 to 4.6%, and the primary reasons for admission are hemorrhage, sepsis, preeclampsia, HIV complications, and tropical diseases. Mortality in these patients can be high and ranges anywhere from 2 to up to 43%. The preventability of maternal deaths and severe outcomes highlights the need for clinical awareness, appropriate evaluation, timely diagnosis, and early intervention in these high-risk obstetrical patients. Before we dive in, we'll briefly review the objectives for today's talk. First, we'll talk about just summarizing the physiologic changes of pregnancy that directly influence how we assess and manage critically ill obstetric patients. Then we'll review some common bedside screening tools, as well as the clinical utility of various types of point of care ultrasound. We'll then identify ICU admission criteria and escalation pathways. Then we'll look at some systems-based strategies, highlight the importance of multidisciplinary collaboration, and discuss challenges to care in low-resource settings. And then finally, we'll talk about the psychological aspects of post-ICU recovery. So starting with summarizing the physiologic changes of pregnancy that are relevant to critical care. We'll start with the cardiovascular system. So changes in the cardiovascular system are profound, and they begin early in pregnancy, primarily by an increase in peripheral vasodilation, which leads to a fall in systemic vascular resistance. Blood pressure decreases in the 1st and 2nd trimesters, and then increases in the 3rd trimester. To compensate for the decrease in systemic vascular resistance, the cardiac output increases by about 40% via increases in stroke volume and rate. The increased stroke volume is likely due to increase in ventricular wall muscle mass and end diastolic volume. The heart is physiologically dilated and myocardial contractility is increased. It's also important to note that labor is associated with further increases in cardiac output, with uterine contractions leading to an autotransfusion of blood. Following delivery, there's also an immediate rise in cardiac output by as high as 60 to 80% due to the relief of the IVC compression and contraction of the uterus. From a critical care standpoint, most of these changes mean that obstetric patients sequester more blood during CPR and have increased CPR circulation demands. From a hematologic standpoint, Plasma volume increases by about 50%, but this expansion is greater than the increase in red blood cell mass. So this leads to a physiologic hemodilutional anemia. Platelets counts can decrease in pregnancy, but usually remain within normal limits. There are also changes in the coagulation system with increases in concentrations of factors 8, 9, and 10. Fibrinogen levels rise by 50%, and fibrinolytic activity is decreased. There are also decreases in concentrations of endogenous anticoagulants, such as antithrombin and protein S, all of which lead to the pregnancy's hypercoagulable state. Maternal positioning is also an important thing to consider with regards to resuscitation, because supine position will lead to increased pressure of the gravid uterus on the IVC, leading to a decrease in venous return, which results in a fall in stroke volume and cardiac output. So when performing CPR, one must also provide left uterine displacement to prevent compression of the IVC. From a respiratory standpoint, changes include a significant increase in oxygen demand due to an increase in the metabolic rate and increased consumption of oxygen. There's a 40 to 50% increase in minute ventilation due to an increase in tidal volume, and this hyperventilation leads to an increase in arterial partial pressure of oxygen, a decrease in the arterial pressure of carbon dioxide, and a decrease in bicarb. This leads to a compensated respiratory alkalosis, which is normal in pregnancy. From an anatomic standpoint, there is an increase in nasal and pharyngeal edema, as well as changes in the laryngeal angle, which can lead to a more challenging intubation as compared to non-pregnant individuals. Renally, vasodilation leads to an increase in blood flow by 40 to 65%, an increase in the glomerular filtration rate by 50 to 85%, and decreased creatinine. The increased blood flow can lead to an increase in renal size, and mechanical compression of the ureters by the gravid uterus can lead to a dilation of the renal system and physiologic hydronephrosis with right greater than left. Urinary stasis in the dilated renal system predisposes the pregnant patient to asymptomatic bacteria and pyelonephritis, as we know. And finally, breast hypertrophy can actually lead to decreased chest wall compliance, which can actually result in needing increased compression force when doing CPR. Next, we'll talk about the clinical utility of bedside screening and imaging tools. A particularly challenging component of providing timely care in obstetric critical illness is the challenging nature of anticipating the critical illness and then the subsequent death. It's estimated that up to 60% of maternal deaths are preventable, including over 70% of deaths from specific causes like maternal sepsis, for example. One of the solutions to address this problem is the implementation of early warning criteria to try to capture patients before they clinically decompensate. Early identification of high-risk obstetric patients allows then, ideally, for the timely referral, resource allocation, and the multidisciplinary planning that's required to take proper care of these patients. In recent years, comorbidity-based screening tools, which quantify a patient's medical comorbidity burden, have been developed and validated in predicting ICU admission and death. The Obstetric Comorbidity Index, or OBCMI, which is displayed here, represents a pretty extensively validated example of a comorbidity screening tool that's tailored specifically for obstetric patients. The OBCMI utilizes a composite of many medical comorbidities, and each one is quantified by or associated with the odds of developing end organ dysfunction. Each medical comorbidity is essentially added up to provide a numerical value, and then that value is representative of the odds ratio for developing severe maternal morbidity at the time of delivery. The OBCMI has also been validated in predicting ICU admission and maternal death across various medications. There was a prospective study that was published in the Great Journal back in 2019 that examined nearly 3,000 obstetrical patients and found that a score of 0 of the OBCMI was associated with a less than 1% incidence of of a patient needing ICU level care, compared with a 12 to 14% incidence of needing ICU level care with a score of 7. This study found that every 1% increase in the OBCMI score was associated with a 1.55 increase in odds in a patient developing severe maternal morbidity. Similar findings were noted in a large population-based study in Denmark and another one in the United States. Another benefit from this type of antepartum risk prediction system is that it can allow for risk-appropriate care and transfer of a patient to a facility with the appropriate resources before the development of a hemodynamically unstable state that may preclude transfer. Another bedside scoring tool that we are much more familiar with here is the Modified or Maternal Early Warning Score, or the MUSE score. This is a physiologic vital sign-based screening tool that's used to predict clinical deterioration in the obstetrical setting. Early warning systems have been in use in the general population since 1999, but due to the physiologic changes in pregnancy, these modified criteria were created. In 2017, SMFM assembled a group to evaluate the use of MUSE in practice, and the group concluded that integrating these tools and having an early warning system were essential ways to optimize capturing patients at risk. These physiologic-based tools are also very easy to use and only require routine bedside observations, so they're very easy to implement in places that have low resource settings. Some challenges, though, with physiologic-based screening tools is that they can lack some specificity. And in addition, these physiologic changes in pregnancy and those during the peripartum period, like intermittent tachycardia and sometimes tachypnea, can pose a particular challenge in using these vital signs in the identification of high-risk patients and clinically predicting if and when they're going to deteriorate. Literature is currently divided regarding the ability of these types of early warning systems to actually affect mortality outcomes. There's many variations of these types of obstetric early warning systems, and one of these is called the Obstetric Early Warning System, or the OEWS. It's a system that was developed in the UK. It, again, similarly does not require any laboratory testing, but it's nice that it incorporates a color scheme as well as a numerical measure of illness severity. This score has been studied and has found to have a very good predictive value for survival after critical care unit admission. And the system has been retrospectively validated in some middle-income countries in South America, showing that the score is able to predict survival in conditions directly related to pregnancy. For some lower resource settings, a single markedly abnormal observation, which is one of the red triggers, or a combination of two simultaneous mildly abnormal observations, or two of the yellow triggers, or a numerical scale sum of 4 points was found to prompt urgent health worker assessment and early treatment. Moving away from the early warning systems and onto some disease-related scoring systems, a great tool to use in hemorrhage is the shock index. The shock index is defined as a ratio between the heart rate and the systolic blood pressure. It's been proposed as a useful and reliable tool to detect and or predict hypovolemia and early hemodynamic compromise in obstetric populations, even when the individual vital signs are within normal limits. A recent study included nearly 1,000 patients with hypovolemic shock secondary to obstetric hemorrhage in low resource settings, and found that the shock index was a strong predictor of all adverse outcomes. The authors recommended that a shock index threshold of about 0.9 indicated the need for referral, 1.4 indicated an urgent need for transportation to a higher level of care, including needing things potentially like surgery and interventional radiology, and a value of 1.7 was associated with a high likelihood of adverse outcomes like admission to a critical care unit, needing massive transfusion, or leading to multiple organ failure and death. One easy way for us as residents to use a score in the management of hemorrhage is to realize that if heart rate is equal to or greater than the systolic blood pressure, that's indicative of at least moderate, if not severe, hypovolemic shock. Another prediction tool, this one for preeclampsia, that's been shown to predict adverse maternal outcomes within 48 hours and up to 7 days for women admitted with preeclampsia at any gestational age, is something called a full Piers score. This here is an example of a full Piers calculator. It has inputs from just an example patient and basically gives you an output of a percentage risk of adverse maternal outcomes. And this can help with decision-making, resource allocation, and to ideally enable timely and targeted interventions for patients, again, when resources are limited. There's also a variation of the full Piers score, which is another tool called the mini Piers. And Piers basically is just the preeclampsia integrated estimate of risk. That's what that stands for. This is a risk prediction model that's specifically geared towards patients in lower resource settings. And the great thing about this model is that the variables included are things like parity, like nulliparity versus multiparity, gestational age on admission, symptoms such as headache, visual disturbances, chest pain, dyspnea, vaginal bleeding with abdominal pain, systolic blood pressure, and dipstick proteinuria. So none of these things include any laboratory or imaging criteria. So it's, again, very readily available in any setting, and it can help identify a woman who potentially would benefit, or a patient who would potentially benefit from interventions such as mag sulfate, antihypertensives, or transportation to a higher level of care. Moving on to some screening in sepsis, the SOFA score, which you've probably heard about, is commonly used in critically ill patients in the ICU to assess organ dysfunction. This scoring system assigns 0 to 4 points to each of the 6 individual organ systems, which are respiratory, cardiovascular, neurologic, hepatic, renal, and coagulation, for a total score ranging from 0 to 24. It's been shown to be effective in the prediction of mortality in a variety of patients admitted to the ICU. In 2016, the Third International Consensus Definitions for Sepsis and Septic Shock Task Force defined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Organ dysfunction is objectively defined as an acute increase in 2 or more points in the SOFA score. A shorter version of the score can be used for easier bedside evaluation. That's the quick SOFA or the Q-SOFA, which looks specifically at 3 markers: systolic blood pressure, respiratory rate, and altered mental status. If 2 or more of those are present, then a patient is at risk, in theory, for poor sepsis-related outcomes. Of the SOFA criteria, those that are most affected by pregnancy, though, are the creatinine and the MAP. So there was an obstetric modified Q-SOFA score that was proposed, which basically includes or has changes based on the physiologic values in pregnancy. It is important to note, though, that sepsis cutoffs for respiratory rate, heart rate, and partial pressure of carbon dioxide, white blood cells, for example, sometimes can overlap with the normal range of pregnancy, labor, and or the early postpartum period, and sometimes can lead to a false positive diagnosis. So obviously it has to be all within clinical suspicion. Another sepsis scoring system in obstetrics is a sepsis in obstetrics score, or the SOS score. It combines parameters taken from other scoring systems like Apache 2 and the REM scores, which are very common ED scoring systems. And it also uses the SIRS criteria and pregnancy-specific parameters. And this system uses scores ranging again from 0 to 4 for each of these variables, with a maximum score of 28. A score of 0 indicates a normal value, and higher points were given for both high and low abnormal values for each variable. When applied to a retrospective cohort of pregnant and postpartum patients, with the clinical suspicion of sepsis, a score of greater than or equal to 6 was independently associated with an increased risk of being in the ICU or telemetry unit admissions, having positive blood cultures, and fetal tachycardia. The scoring system was found to have a positive predictive value of 16.7% for admissions to the ICU. Because pregnant and postpartum women are generally young and without chronic medical conditions, their actual rate of SIRS and sepsis-related morbidity is low, so the positive predictive value of any given score is usually low, but this particular score seems to have a better positive predictive value than either like the REM score that's commonly used in the ED or the Muse scores. It also has an 89% sensitivity and 99% specificity, which is also pretty good. Another promising avenue for early identification of maternal critical illness is that using artificial intelligence. A couple of studies that were done abstracting patient data from the electronic medical records and using diagnosis codes and then using artificial intelligence methods to stratify women into high-risk groups for developing severe morbidity. A lot more research needs to be done in this field to show improvements in outcomes, but some of the early studies that have been done show the potential utility of AI risk prediction tools in the antenatal setting. Next, we're going to shift gears slightly and talk about a different type of bedside screening tool, which is point-of-care ultrasound, or POCUS. This has gained increasing importance in the management of high-risk pregnancies. It's already been widely accepted in the ICU and emergency medicine settings for rapid assessment of conditions like shock, trauma, acute respiratory failure, DVT, and limited cardiac assessment. In pregnancy, lung ultrasound has actually been evaluated in healthy women, mostly in the 3rd trimester of pregnancy, intrapartum, and early postpartum. And studies report that approximately 75% of healthy women in the 3rd trimester of pregnancy have a lung ultrasound pattern similar to non-pregnant individuals, which suggests that the physiologic changes of pregnancy and postpartum actually don't alter the normal lung ultrasound pattern. Lung ultrasound has been shown to be helpful in things like preeclampsia to identify patients at a higher risk of pulmonary edema before they actually have signs of clinical deterioration. These images are lung ultrasound images that demonstrate something called B lines. These lines are present when the lung loses its normal aeration, but it's not completely consolidated. So it can be seen in a variety of different conditions, but specific to what we're talking about in patients with preeclampsia, this finding can suggest extravascular lung water accumulation, and the presence of multiple of these B lines is a validated finding for the diagnosis of pulmonary edema and lung inflammation in critically ill patients. The diagnostic accuracy of the lung ultrasound is actually superior when compared to a standard chest X-ray, with a sensitivity and specificity of 86% and 97% in identifying pulmonary edema, respectively. Ultrasound can also be used to assess disease resolution, as a real-time sonographic clearance of these B lines is actually correlated with patients that are undergoing diuresis. Lung ultrasound in pregnancy has also been studied in other clinical situations besides preeclampsia. For example, in pregnancies that are complicated or complicated by COVID infection.
Okay, love you, bye.
Lung ultrasound showed characteristic features such as irregular pleural lines and patchy areas of white lung, as you can see in these images here. And this is similar to what's been described in non-pregnant individuals with these conditions. To this date, though, there are no guidelines or specific obstetric protocols to guide the application of lung ultrasound in pregnancy, and we need larger prospective studies to standardize this technique and use clinical criteria to determine the actual clinical utility of lung ultrasound. Another great ultrasound tool is the assessment of volume status and the response to volume resuscitation using bedside ultrasound of the IVC diameter. Studies have shown that the diameter and collapsibility of the IVC correlates with central venous pressure and therefore provides important information on patients' volume status. A small and collapsible IVC with significant diameter variation with the respiratory cycle usually suggests hypovolemia, whereas a dilated IVC without diameter changes suggests euvolemia or volume overload, which can help to guide fluid management. IVC assessment appeared to be accurate in predicting post-anesthesia spinal hypotension in pregnant women undergoing a C-section. And there was a randomized control trial that was actually done in non-pregnant individuals that looked at the IVC index based on ultrasound, and its guided fluid therapy was actually associated with a 35% reduction in the incidence of post-anesthesia hypotensions. Another commonly used application for abdominal ultrasound, as we know, is the FAST exam. This is commonly used in the trauma setting to screen for patients with potential intra-abdominal hemorrhage, and has overall very good sensitivity. Bless you. The views in a traditional FAST exam include the right upper quadrant to look at Morrison's pouch, which is the area in between the liver and the right kidney. Looking at the left upper quadrant, the space between the spleen and the left kidney. And then the pelvic view to look at the uterus, posterior cul-de-sac, and bladder. Also the cardiac view to look for pericardial effusion, and lung views to look for pulmonary edema or pleural effusions. For our purposes, the most high yield areas that we essentially would be looking at are the right upper quadrant, the left upper quadrant, and the pelvic views. Another use of FAST exams is actually looking at ascites in pregnant patients with severe preeclampsia, as studies have found that high rates of ascites is associated with an increased risk of outcomes. Bless you. Next, we'll discuss the criteria for escalation of care to the ICU. So hospitals differ in their configuration of care for women who are critically ill during pregnancy, birth, or the postpartum period. The underlying principle of caring for any sick, pregnant, or recently pregnant woman is that they're looked after by someone with the appropriate competencies in the appropriate place in the hospital. To standardize an integrated system of perinatal regionalization and risk-appropriate maternal care, ACOG made a classification system that establishes essentially 4 levels of maternal care. Level 1 is basic care that's there for Level 1 is basic care that's there for low to moderate risk pregnancies. They also have a level for an accredited birth center, which is care for low risk women with very uncomplicated singleton term vertex pregnancies who are expected to have an uncomplicated birth. Level 2 care is basically specialty care for moderate to high risk pregnancies, and these locations generally have capabilities like having CT scans, MRI, echo, and just the standard obstetric and neonatal management. Level 3 involves subspecialty care for more complex maternal and medical conditions, obstetric complications, and fetal conditions, and again include those places with capabilities that include availability for all blood products, imaging capabilities like CT scan, MRI, maternal echocardiography, non-obstetric and obstetric ultrasound imaging, and IR capabilities. Also, ideally, these locations will have on-site medical and surgical ICUs that will be able to accommodate and take care of very critically ill patients. And then finally, we have level 4 centers, which are essentially regional perinatal healthcare centers. And these have the ability to care for ideally the most complex maternal conditions and critically ill patients throughout their entire antepartum, intrapartum, and postpartum care. And so these facilities should include on-site medical and surgical care of complex medical conditions with the availability of critical care unit or ICU beds. The care of any pregnant woman who requires ICU services ideally should be managed in a facility with obstetrics, adult ICU, and neonatal ICU capability. Maternal transport facilitates access to a higher level of care for the woman and the patient and the neonate when necessary. Necessary transport monitoring for a critically ill pregnant woman, patient, or for a patient during the postpartum period includes continuous cardiac rhythm and pulse oximetry monitoring and regular assessment of vital signs. Venous access must be established before transport, and all existing lines should be secured. Left uterine displacement, like we talked about, should be routine during transport. And if there's a high probability that intubation or mechanical ventilation will be needed during transport, it should be ideally accomplished before departure. The Society for Critical Care Medicine made a guideline for the rational allocation of critical care beds, which is shown in the chart here. For this allocation system, patients are basically prioritized based on their severity of illness and likelihood of recovery within the ICU therapies. Essentially, the guidelines suggest that guiding ICU admissions on the base of a combination of specific patient needs that can only be addressed in the ICU environment, such as life supportive therapies, available clinical expertise, prioritization according to the patient's condition, diagnosis, bed availability, objective parameters at the time of referral, such as respiratory rate, potential for the patient to then benefit from these interventions, and finally, prognosis. Essentially, the overall meaning of all of this is that the underlying principle is that individual institutions and their ICU leaders should develop policies to meet their patients' needs with the consideration of the available resources at each individual location. Next, we'll examine some systems-based strategies to manage critically ill obstetric patients, review some challenges to care in low-resource settings. Like in all aspects of medicine, looking for the unwell pregnant patient is a team sport, and it requires multidisciplinary groups. Knowing the ICU model and type at your location or at your hospital will help to define the obstetrician's role in patient care, which may be as the primary physician or as a consultant to the intensivist team. In an open model, the patient remains the responsibility of the primary or referring team. In a closed model, the patient is transferred completely to the ICU team, which then takes over sole responsibility of managing the patient and writing orders and everything. And a hybrid, transitional, or semi-open model is one in which the primary team still admits to the ICU, but there's an automatic critical care consult that's incurred. So it's more of a collaboration. Multidisciplinary care plans should be developed at all times with attention to maternal and, when relevant, fetal status. Decisions must be made about fetal monitoring based on the gestational age of the fetus, desires of the patient and her family, and feasibility of interventions based on maternal status. Ideally, planning for delivery should include a discussion of the preferred mode, the location of delivery, the need for analgesia or anesthesia, the availability of pediatricians for neonatal resuscitation. Because the risk-benefit considerations for continued pregnancy versus delivery are likely to change as the pregnancy continues, the care plan must be reevaluated very regularly. And in situations when there is an acute deterioration in the patient's clinical condition, immediate reassessment of continuing the pregnancy versus delivery should be undertaken. An innovative model of care to address the limited ICU resources is something called the virtual obstetrics ICU model. This essentially involves like a virtual ICU team that's composed of pre-selected specialists from multiple disciplines like MFM, intensivists, cardiologists, pulmonologists, anesthesiologists, obstetric and critical care nurses, respiratory therapists, and clinical pharmacologists. And essentially this entire group of people can participate in the patient's care. With the help of telemedicine, this type of team can work in theory in any setting and kind of create like a mobile multi-specialty team that can take care of patients in any unit in the hospital or at different hospitals. This model has actually been tried and shown to be successful in countries such as Australia, but it's not that widespread yet. So we know that intensive care bed units are a scarce resource. So now we're just going to talk a little bit more about challenges in places that have resource-limited settings. There's estimated to be an 8-fold difference among high-income countries to low-income countries with regards to ICU bed and availability. The challenges to maternal critical care in low-resource settings is similar to those found in general healthcare, such as lack of drugs, equipment, supporting infrastructure and trained personnel, inadequate transportation, long lead times to hospital admission, evaluation, treatment, and transfer to surgical facilities and a critical care unit, as well as late and severe presentations of disease that's secondary to poor access to appropriate care. This reality is made even more challenging because low resource settings have a higher proportion of pregnant and postpartum individuals that require admission to critical care units compared to those with high income countries. It's been estimated that as many as almost 5% of all deliveries will require critical care support in lower and middle income countries. There's some strategies to identify critically ill patients and enable early and appropriate management and thus prevent avoidable critical care admissions. These strategies ideally need to be clinically based and not rely on expensive diagnostic modalities and monitoring and therapeutic options that are not readily available in low resource settings. Some simple interventions that are known to be effective and inexpensive include things like early resuscitation with fluids and antibiotics in sepsis, intravenous mag sulfate for the treatment and prevention of eclampsia, antihypertensive drugs for severe hypertension, the use of uterotonics for the prevention of postpartum hemorrhage during the 3rd stage of labor for all births, early administration of TXA to women with postpartum hemorrhage, transportation to a higher level of care, and administration of antenatal corticosteroids. There's also some newer technologies that have been specifically designed for places with low resources, one of which is called the CRADLE, which is the Community Blood Pressure Monitoring System in rural Africa and Asia. They've created this vital signs alert, which is basically a handheld upper arm semi-automated device that measures blood pressure and heart rate. This device has been validated in pregnancy, including those who have hypotension and hypertension with preeclampsia. And the monitor meets the WHO criteria for applicability to low resource settings because it's a robust and portable device. It requires very minimal calibration and it has very low power requirements and it's very affordable, about $25 per unit. This device also has, with the newer modifications, traffic light early warning systems, so it can alert healthcare workers and, most importantly, untrained users to vital sign abnormalities. So it's very user-friendly, very easy to use, and anyone in any community resource could potentially use it and know what to do with it. Another kind of new technology, the screening tool that we already talked about is the mini Peers. There's actually an app that's associated with that called Peers on the Move. It's a low-cost, easy-to-use app that's been developed to, again, aid healthcare workers in making decisions on the management of women with preeclampsia. The app is basically based on a decision model that combines the accurate risk prediction of maternal adverse outcomes related to patients with having preeclampsia, and it also incorporates WHO recommendations for the management of preeclampsia. The app also uses an integrated pulse oximetry sensor that you can connect to your phone, which allows for integrated measurements of oxygen saturation as well, which is pretty cool. Another thing that we talked about is a virtual ICU unit, which can also be applied to patients or places with low resource settings. But getting the appropriate hardware and having consistent internet connections to make this feasible is probably going to be pretty challenging. So it's a little bit challenging to allow it to have a large scale adaptation. Another really cool technology is the use of blood delivering drones. There's a California-based startup called Zipline, which developed a technology to use drones to deliver blood to remote villages in East Africa. And since 2011, they've been working with the government of Rwanda to deliver blood supplies to about 21 regional hospitals within the area. And it's all located within a central hub within one of the major cities in Rwanda. They launch more than 50 drones daily for on-demand deliveries. And the company is planning on expanding further to be able to deliver other medical supplies, vaccines, and medicines to hundreds of clinics in Rwanda. And they're also branching out to Tanzania, and I heard Canada as well. Finally, a new strategy that's currently under evaluation is the use of solar energy to power oxygen concentrators, which can generate oxygen on site from ambient air. These concentrators would be great because they would overcome the logistic supply barriers of having cylinder oxygen, and they would require minimal service and maintenance, and they're a lot more user-friendly than oxygen cylinders as well. So things in the works. Finally, we'll just talk about the psychological aspects of post-ICU recovery. So as we know, care for the critically ill obstetric patient doesn't end after the life-saving intervention. A traumatic birth experience can have a very detrimental effect on maternal psychological health and can be associated with the development of post-traumatic stress disorder. Subjective birth experience is the strongest predictor of postnatal trauma. Maternal critical illness is nearly always an unexpected and frightening experience for the pregnant person and their families. Patients can experience fear, frustration, disempowerment, and shock during the immediate emergency, and then also have symptoms of anxiety, alienation, and flashbacks in the aftermath. There was a 2015 qualitative study that was done in the UK that looked at women who had experienced a life-threatening complication in pregnancy. This study was really cool because it highlighted the shock experienced by women who had required critical care and the differences between their expectations of birth and what had actually happened. Here are some key quotes from the study. With regards to being woken up in a critical care unit, one patient said, "I woke up in the ITU or intensive therapy unit with my partner on one side in scrubs, which was frightening. I thought, where on earth am I? I thought, what's happened here? Looking around, I remember seeing some people sobbing around the bed, and I thought, I'm not on a maternity ward. What's going on?" Another patient said, "You have this idealistic picture in your head of what it's like when you've got a baby, that you'll spend all of your time cuddling with them, and I didn't feel like I could do that because just holding him at first was just exhausting. So that was a really difficult sort of emotional battle, really." With regards to breastfeeding, one patient said, "I was just insistent that I was going to do it because I hadn't even managed this natural birth that I wanted, and they thought, there's no way I'm not feeding this baby." And kind of conversely, another patient said, "After what you've been through, nobody would look down on you and say that you've not tried." And having that, a provider say that to them made them feel so much better about having made the decision to stop expressing and stop breastfeeding. It felt like a big weight off my shoulders. And then finally, with regards to just the transfer out of critical care, I think this is a really powerful quote. And the patient said, "That day I was moved onto the normal ward, and I'm not going to lie, it was hard. It was like my family's fight was over because I was awake, but my fight had only just begun because not only did I have a newborn baby and a 3-year-old at home, but I also had the fact now that I can't have any more children. Accepting that I'm not invincible, I nearly died. Also the fact that I couldn't even move because my muscles had deteriorated completely. I couldn't even press the buzzer to call the nurse. I was that weak. So it was like I had to start from the beginning." Essentially, the study findings highlighted both the challenges and the value of being able to keep the patient and the baby together, though this is often not possible. So developing protocols to allow the patient to visit the baby or vice versa was found to be very helpful in patients' recovery. And if this is also not possible, then most patients really just appreciated being kept in touch with the baby's progress through photos, updates, or direct contact with the baby's pediatrician team. Another fundamental principle from this study was to make sure that the pregnancy cares continued and integrated throughout this entire experience. Transferring out of the ICU, as we've seen, can cause relocation stress, and there's physical and non-physical morbidities that can affect patients who have required critical care services, like ICU-acquired weakness, leading to difficulties caring for themselves and caring for the baby. Early mobilization in the ICU, along with early PT and OT services, have led to better outcomes. ICU follow-up services have also been shown to be helpful in physical, emotional, and psychological recovery. In the setting of this, just wanted to go over a few mental health resources that we have for patients in our area. One resource called the Madison Postpartum Collective is really great. It has a lot of great resources for both patients and providers that are looking for individual or group support, and they have it categorized by different types of mental illness or different types of stressors that the patients may be experiencing, which is really helpful. Another one is called the Postpartum Support International, which has a Wisconsin chapter. This also has really great resources and specifically has a very easy to use online directory to find any qualified perinatal mental health professionals in any specific area. Just click on the link and insert a particular zip code and it'll list a bunch of perinatal providers within the area. So it makes it really easy to use. And then finally, one that people have probably heard about before, the Periscope Project. This is a resource that's specifically for providers to get a quick teleconsult between the provider and a perinatal psychiatrist to obtain recommendations on the management of a patient. Essentially, you call them, you leave a message, and then in theory, they answer your phone call within 30 minutes, and you can chat with them about any concerns that you have about taking care of a patient, and they'll provide you with recommendations. So as we wrap up, just want to go over a couple of key take-home messages. First, remember, pregnancy physiology matters. The normal parameters shift, cardiac output increases, creatinine drops, respiratory changes can mask early hypoxia, and if we don't account for these changes, we can risk misinterpreting early signs of decompensation. Second, don't wait to escalate. One of the most common contributors to preventable maternal morbidity is a delayed recognition of transfer. So use your early warning signs and bedside tools to evaluate the patient quickly and effectively. Third, critical care in obstetrics is a team sport. Multidisciplinary collaboration and standardized protocols are what lead to the best outcomes. And finally, recovery doesn't end at discharge. Many of our patients will survive critical illness, but then face lingering psychological, physical, or bonding challenges. So our roles as obstetricians extends to trauma-informed care beyond the ICU. Thank you all for your attention. Happy to take any questions.
With the rise in maternity care deserts, like domestically here in the US, do you feel like there are parallels between like these areas and the criteria that you presented for low resource settings? And then if so, did any of the innovative approaches that you presented or came across in your research feel like particularly applicable here domestically for those maternity care deserts?
Yeah, I mean, I think it definitely does. I think a low resource setting can be anywhere. It doesn't necessarily have to be like in like lower or middle income countries. So that definitely applies. I think that some of the strategies that honestly can be really helpful are the things that don't require a lot of like extensive laboratory and imaging criteria. So I think using some of those early like screening tools and guidelines and trying to establish a better protocol for point of care ultrasound can make it a lot easier to have like rapid and quick assessments of patients, especially when you're in a location where it's going to take a long time to get labs back, or it's going to take a long time to get this patient to a CT to see if they have pulmonary edema or something like that. And so trying to utilize these other methods that can at least make it so that you are aware that this patient is potentially getting worse or clinically is going to require a higher level of care to stabilize them and then transport them to a place that can have more resources to be able to adequately take care of them.
Are you going to be working with residents in your practice?
I will, yes.
What, among all of the skills that you gained from working with Dr. Gaston and Dr. Lawlitz, Dr. Espinoza, and all of our MFM colleagues, all of those like with extra critical care training, what tools or skills do you depend on as a resident when you're first evaluating a sick patient on L&D that you're going to want to like teach and pass down to your trainees?
Yeah, I think one of the things that we've been kind of hammered into our minds is to always have a high clinical suspicion for like everything pretty much, and always start out with a very broad differential and then narrow down like as the clinical picture evolves. And so always whenever you see patients with vital sign abnormalities, sometimes we tend to think, oh, it's probably they're just dehydrated or something like that. But then to really think back and make sure like, well, are they meeting search criteria? Is this something that I need to evaluate further and get more labs? And so always keeping the differential broad to start and then narrow down as things go. Another thing that I think has been really helpful is Dr. Gaston loves to do point of care ultrasound, like doing point of care echoes, which essentially I'm not trained to do that, so I can't teach anyone how to do that, but at least like doing fast scans I think can be really helpful, again, especially in a place where you don't have very easy access to other imaging modalities, as easy as we do here at least.
I have a question. This was great. I really appreciate it. And I just wanted to know if you could comment on what you think are some of the strengths of our OB critical care practice, if you will, and then what are some of the opportunities or ways that we could improve? And I know it's a big question.
Yeah.
And it's coming from the chair of the department, so I don't need to put you on the spot. You don't have to answer it in a minute, but you've put a lot of time into it. You're well trained, and I just think if you have some ideas right off, great, and beyond that, if you have some ideas from your perspective, I'd love to hear them.
Yeah, absolutely. I think from a strength standpoint, I think we're really strong, especially with how quickly we can mobilize care for patients. And I think we've been like continuously working on how quickly we can do that. Like, for example, when we want to get IR for someone to do like a uterine artery embolization, I think we've made a lot of moves to try to make that as efficient as possible. In the past, it used to be a lot more complicated. But I think the fact that we have a really strong critical care unit here and have a lot of very strong providers that have background in critical care medicine and are able to use those skills to take care of patients, I think is very helpful. One thing that definitely is really challenging is the inter-hospital transport, even though everywhere is kind of close to each other, going from East Madison to Meriter or UW to Meriter, and the fact that we only have obstetrics here, but have some of the other like more critical care capabilities like ECMO and cardiac and respiratory monitoring over at UW can sometimes make those a little bit more challenging. But I'll think about that further and see if I have any other thoughts of things we could do to improve.
All right, well done.